So very good morning as well as good evening to the nephro critical care colleagues across the world. Thank you, Tapas. Thank you, Dr. Ramanathan, as well as the entire colleagues of mine, both from India as well as here, for giving me this opportunity. As being the part of this nephrocritical care's fast conventions at Ranchi to the many other programs, I'm really blessed and feel grateful to be part of these things. I do not have any disclosure except the fact I'm a clinician. I love what I do at bedside, and on top of that, I love to educate the younger generations and do some specific interest of mine, like acute kidney injury, as well as extracorporeal therapies in my center here at Florida Mayo Clinic. By the end of my talk, what I believe the participants should be able to know what are the extracorporeal therapies was being used in the management of sepsis, what are the challenges, and where we stand in respect to their applications in the day-to-day practice of critical care or nephrology or medicine in general. To start with, I would go for a, I would say, clinical case, because this is what we usually start with and ask questions to ourselves. How do we do and what should we do? What are the evidence and what's the best way to manage this patient? This patient was in our ICU at beginning of 2022. He's a 76-year-old gentleman, underlying history of hypertension, diabetes, coronary disease. His EF was like 35% because of the prior coronary disease, ischemic cardiomyopathy. He underwent cystoscopic and laser removal of the prostate. 12 hours into the surgery, he's landed in our ICU with hypoxemic respiratory failure. There are quote-unquote post-potential aspiration, but we are not sure. So he failed the conventional mechanical ventilation strategy because he was hypoxemic, hypercapnic. We tried to do our best with the conventional mechanical ventilations. Even we started proning, that didn't help. So the team also take a clinical decision making, which I'll tell what happened after that. Mainly, to be honest, like he was started on VV ECMO. Unfortunately, the next 24 to 48 hours, he continued to deteriorate, require inotropic support, renal failure, needed dialysis with a quote-unquote diagnosis of refractory septic shock. We can debate about that. Why do we cannulated this patient for VV ECMO? What are the evidence? And when did we started the kidney replacement therapy? Did we consider other kind of extracorporeal therapy? If your primary diagnosis or the hypothesis that why this patient is deteriorating is because of the sepsis, without having any definitive evidence, which is the real world scenario, because if we go by the sepsis 3 criteria, he fills into that, but the objective criteria for sepsis, which includes the bacteria, was not available while we are doing all these things in this almost octogenarian patient. Then that comes to the other questions, like how many of you would really believe that ECMO is a form of extracorporeal therapy? So there are many semantic about that. Some people believe it, some people do not believe it because of the nature. The only thing I can certainly say that the extracorporeal carbon dioxide removal can be called as a therapy for the ECMO. And so also the ECMO, when it is used in cardiac arrest, it can be called as a therapy. In other type, the ECMO or the other mechanical circulatory device such as Impella or the kidney support system, they are not really therapy. We are just doing some support, but that's also debatable. That comes to the next question. So what are the extracorporeal system when we comes to utilize in our patient at the bedside, and how they are classified? I put them into two types. The one is the blood purification system, and then the other one is the hemodynamic system. They can be used in combinations or all alone, depending upon the need. And there are many types. So we'll go one by one, maybe try to find out where do we stand in their utilizations at the bedside. This is kind of a in general pictorial form of the various organ system support. As you know, the VV ECMO stands for veno-venous ECMO, veno-arterial ECMO, SCOP, which you all probably knew that, and various form of continuous renal replacement therapy, plasma exchange, and MARS, you name it. So these are all extracorporeal support system, which has been traditionally in use with patients, those who have sepsis, septic shock, and organ dysfunction. So the question we have to know that what are the physiological principles behind their application? How do we feel that they usually help our patients, those who have on this kind of scenario? If you club to the physiological principle of all the extracorporeal therapies, they can be of three types. One is absorption, convection, and diffusion. This is the only three physiological principles on the basis of which they work. There is nothing magic on that. And you all have to go back to your physiology class and to understand how they work in general. But there are some common shared principle, all these therapies. They all need external devices or machine, you can say that. They need vascular access to get the blood from the patient. That's why they call the extracorporeal, because you are removing the blood from the patient. And they all ask for anticoagulation and some moment of their utilization, otherwise they will not function properly. The other things we all have to know that when you add the extracorporeal therapies to the patient care at the bedside, they change the pharmacokinetics and pharmacodynamic of your patient. So in that case, what you all have to understand that you have to be careful about know how the medications we are giving, how these therapies will change the overall equilibrium of the patient's care at the bedside. And the most important factor, we all have to understand that the success of this extracorporeal therapy in patient care depends upon the patient selection and the timing of the interventions, which is the very challenging things for the nephrologists and the extracorporeal therapy or intensivists. The question arises why we all need to know about that, because you know, we are all have a board certifications, everything, we know the physiological principle, and what is the need. The need is that we are living in the era, we call it the era of machines. So all the ICU and ICU as well as the hospitals are full with all the machines, and we all have to know the nitty-gritty. And then the important point with concept come to the sepsis care, that sepsis has been a challenge for years, like probably years since the medicine. Currently, almost 50 million people across the globe are affected by sepsis. And then sepsis therapy remains static, though there is some human mortality currently, depending upon which paper we explore. The mortality is almost like 30 to 40%. There are some longitudinal data. It says that in the last 1 decade, the sepsis-related death has been decreasing. And we all knew that we are living in the technological era, that many of these technology are helping us to decide how to do the best for our patient. And the most important thing is that we just came out of the pandemic, COVID-19. It has definitely changed our life many ways for many people. Like one of the things I just wanted to say that prior to COVID-19, since in the last 1 decade, everybody used to say that you cannot use ECMO in the care of the patients, and even particularly the sepsis. But what we knew that during the COVID, ECMO has been used more than 15,000 patients. It has definitely make a dent in the mortality and helped many other people. Perhaps the combination has also made a change. The things what we had to really understand that we are considering ECMO as the new mechanical ventilator. That's what prompted us in our hospital, particularly the gentleman I shared, that why we used ECMO as the initially, because it was refractory hypoxemia. We waited and then kind of tick mark or check mark the Eolia trial criteria, and then he fit into that. That's why we went into the mechanical ventilator. But the question arises, is the extracorporeal therapy, which are other extracorporeal therapies, are the standard of care right now, and should we use them regularly at the care of these people? We'll have probably some slides in the discussion going forward. But before we jump to that, what we all have to accept that the paradigm of sepsis care as well as the sepsis pathophysiology has been changed. Gone are those prior definition where you used to think that sepsis is because of the damage induced by the pathogen. What is the current understanding is that it is a mismatch. That means the patient is getting damaged because of the immune activations, and then the side effect of the immune activations to control the infections is causing to the organ damage, and we need to balance that somehow by many methods. So that brings to, we call this called the ABC of the sepsis care. What is time tested and having a lot of evidence, it seems that the agent, you have to use the antimicrobial as soon as possible, depending upon your antimicrobial at your hospital. And we have to find out the source, like which is it pulmonary, is abdominal, or it is a genitourinary or skin and soft tissue. So that is the most important, and the time tested evidence-based practice we need to like almost preach and practice at the bedside, and that's there. But the other two, the byproducts, anti-endotoxin or cytokines, anticoagulations, or the organ systems remains a debate, because these are called adjunctive therapy, and we are not sure at what moment, whether we should use it early or late, and how we should do. Since the talk is to find out the extracorporeal therapy, how it is revolutionizing the care process, I would say that the therapy or the organ system which has been utilized in the sepsis can be three types: the renal replacement or kidney replacement therapy, MARS, and mechanical circular devices. I'll go from the bottom to top, like the most like mechanical circular device, and that important is the use of ECMO. You can question me why I'm bringing the ECMO. Number one is I love ECMO. Number two is that I still believe that it's the ultimate rescue therapy for septic shock. If the patient has respiratory failure as well as shock, the only extracorporeal therapy and mechanical circular device is currently available who has the benefit, who can provide both respiratory as well as cardiac support, is ECMO. Without going to the nitty-gritty and then pros and cons of the ECMO, that's for a separate topic. So I said that this is what we have and we should be thinking about it. Then you can ask me, what are the evidence for that? As I said, prior to COVID, even prior to the last 8-9 years, there will be sepsis, ECMO, it will be contraindication, except some pediatric patients that used to be data. But now we have adult patients or many small case series prospective trial. There is no randomized control trial for sure, but as shown in the picture, you can see that the overall survival with these patients are better if they have low ejection fraction. That means less than 20%. In other way, people those who are sepsis, and you can prove that they have probably septic cardiomyopathy, and you can consider ECMO in this patient, they have good outcome. Again, these are small retrospective studies, but the data is in favor. In our patient, as I said, the patient was having the EF of 35% when we considered the ECMO initially because of respiratory failure. His EF was dropped a little bit, but that was not for us to decide going for the VA ECMO right away, because his shock, renal failure, everything comes after 36 hours. So coming to the next question, so which is the most common extracorporeal therapy in the ICU? Possibly you all know the answer. The most common extracorporeal therapy in the ICU is the kidney replacement therapy, either continuous or the intermittent form of the renal replacement therapy. How does they function? They definitely replace the kidney function for sure, but they also help into blood purification because of the diffusion as well as the convective clearance method, what I mentioned as the physiological principle behind all the extracorporeal therapy. But we should not be stopped there. The question is, as someone was asking on the chat box, that does the kidney replacement therapy really help the septic patient, and what time and which method we should use? This is probably the most common and challenging questions as a nephrologist and intensivist you will face at the bedside. Unfortunately, you do not have so-called robust answer to follow one path versus the other way. In the last, almost I would say that last 7 years or 8 years, there are tsunami of the kidney replacement therapy in the literature, starting from Ilan, Ekiki, Ideal ICU, Start AKI, and Ekiki 2, you name it. So the nephrology community in general are jumping into the conclusion of the various trials depending upon their need. But one thing I can tell you that in the role of early kidney replacement therapy in the management of sepsis is almost gone. We should be saying that there is no role. It doesn't really help. Why? It is definitely associated with so-called complications, and it's resource intensive. But there are also the other point that does delayed renal replacement therapy or kidney replacement therapy helps. There is some data, yes. So the perfect point at which I need to pull the trigger for renal replacement therapy is movable as well as individualized at the bedside. It's called the risk versus balance things. So to take home message, there is no outcome difference between the continuous versus intermittent therapy. But we have to know that the conventional filters which are used in the renal replacement therapy machines do not remove the cytokines or endotoxin, which should be the goal in case of extracorporeal therapy for the sepsis management. That's why it brings to the non-classic form of extracorporeal therapy in the ICU. They are also called various types. One is the therapeutic plasma exchange. The other one is called liver support system or the MARS. And the last not but the least is the various blood purification system, which I believe most of you wanted to know what are their application and where we stand. So all these non-classic extracorporeal therapies target three parts of the equation in the sepsis care. One, they target or try to remove the endotoxin. They try to remove the cytokines. They also try to remove some of the activated immune cells or the pathogens in general. The hypothesis behind all these extracorporeal therapies, how they can improve the sepsis care as well as help our patients remains on the three. Possibly, if you reduce the toxic cytokines level and probably modulate the immune process, we'll have some better result. So there are case series, randomized controlled trial on this part. We'll go one by one and then see where we are. But before I jump into that, I would like to ask, which is the most common non-classic extracorporeal therapy in the ICU? I'm not sure. This is not a question and answer, but I'll give you the answer is that therapeutic plasma exchange. And how does therapeutic plasma exchange helps? Because you are removing the plasma and then replacing with some FFPF albumin. The principle remains same like the other one. You have diffusive, convective, and adsorption as the things. Maybe the additional part here is replacement. Therapeutic plasma exchange for the benefits of sepsis or any other disease process can be better if you know the plasma binding protein is more than 80-90% and volume of distribution. So that's kind of more in general. So there are many caveats to the utilization of therapeutic plasma exchange. What's the data? To be honest, the Atherapeutic Society doesn't recommend use of therapeutic plasma exchange in the sepsis. But there are many prospective and small activities also. Even one was last year, and then just last month, July, maybe 2 months back, there is a paper which network meta-analysis published in Critical Care with 60 randomized controlled trial with 17 different types of extracorporeal therapy. The conclusion of the network meta-analysis is really interesting. Out of all the extracorporeal therapy, they have found that plasma exchange as well as polymyxin B, which I'm going to talk in the next couple of slides, has been shown to reduce mortality. And then, as I mentioned here, you can see that the relative rate of reduction is 0.61. So this is what the latest evidence for the therapeutic plasma exchange to know about. Moving from the other form of the blood purification system, there are many. The classification system varies also, but in general, they are called one, high volume hemofiltration. As all of you probably know that hemofiltration is the process in which we also do the renal replacement therapy to remove the fluid. High cutoff membrane also, that's it. The high cutoff membrane here, the membrane diameter is higher than the conventional filter we use for dialysis. The normal conventional filter, usually 10 nanometer, the high cutoff membranes are almost 20 nanometers. The other ones is called hemoperfusion or continuous plasma filtration coupled absorption. The technology for the hemoperfusion or the CPPA is that it is more biocompatible and it's shown to be more helpful in some studies. But in the blood purification system, out of all these four, the cytokine adsorption method, mainly by the hemoperfusion, is the most promising extracorporeal therapy available in the market so far, and the polymyxin fits into that. So how do they help really? One, they bind the inflammatory mediators and bacterial toxins and cytokines. There is also evidence that they modulate the leukocytes as well as the activated leukocytes and some of the pathogens. The question is, where does the evidence start, or where is the research is going on? So I would go by one, because in the interest for all these blood purification systems has been there for years. In the last 20 years, there are many trials, and COVID has put more fire into this equation and then questions. So to start with hemofiltration, the Ivory trial, which was published in 2013, between almost like 60 patients, mortality difference was, there is not. This was according to a smaller trial previously, high volume versus low volume hemofiltration and sepsis. They are shown to have improved hemodynamics, but Ivory trial was negative. Then high cutoff, as I said, here the pore diameter is higher. The HICA study, which is randomized control trial, was stopped early in 2008 because there was no difference in the 28 days mortality between the group, those who are on high cost versus, high cutoff versus the other. The best evidence so far, and then multiple RCT, is on the polymyxin. This is the hemoperfusion cartridge combined with polymyxin, and it can be fit into the extracorporeal circuit. The UFES trial was the initial trial, which kind of a small 50 or 64 patients generated a lot of interest because of the positive trial, P of 0.01. However, the next two trials, or the three trials, I would say, that Abdomix and Euphrates, the last one is the largest, Euphrates 2017, there is no difference. And as I said, the randomized control trial network meta-analysis does show that there is some mortality reduction with polymyxin B. So the jury is out whether you wanted to take and what time. So I'll leave it to the people to decide. What about CytoSurf? That's another hemoperfusion cartridge that's being a little bit different in comparison to the polymyxin. CytoSurf doesn't remove the endotoxin. It's just remove the it doesn't remove the endotoxin, but it does remove the anti-inflammatory cytokines. But it is associated with thrombogenicity. Oxiris is another cartridge. It has been shown to be helpful in some small trials, but it is associated with heat, and they remove the micronutrients, and because of the large pore size. And then the coupled plasma filtration there is two trials, none of them really shown to be benefit. So these are all these cartridges are meant to remove the cytokines and endotoxin. What about removal of the pathogen? Do we have something there? Or is anything been done on that aspect? The answer is yes. Like you can see that there are some of the blood purification cartridges which can directly bind the virus or bacteria or other pathogen or their components and to remove them. But none of them are prime time to be utilized at the bedside. So there are many controversies remain to their applications. So I told you all about the individual application of this blood purification system. If they are not helpful in a single way, can we combine them and it will have a different outcome? That is the question, and then paradigm change happened during the COVID because people try to do their best in the absence of definitive therapy for the COVID virus, and then superadded bacterial infection and sepsis. So one of the things which was done at that time is combining the various extracorporeal therapy, which includes ECMO and other things. one of the component of this, or one of the trials which was done, and not trial, probably prospective, is the combination of ECMO with the cytosol. And this is how the picture it shows that they have a cartridge, the white one. Here you can see that, and that's being fixed into or connected to the ECMO circuit, and then they wanted to see what happened. So what was the result of the cytosol? This was published just this year. You can see that 100%, there is a survival benefit with 86%. The more important that the paper says that earlier intervention is associated with certain organ support, need for organ support in ICU stay, and there is no device-related adverse events. So the conclusion says that maybe we have to approach or accept the concept of enhanced long rest. This is where the combination of ECMO and hemoadsorption in the ARDS as well as the septic patient stands, the largest one. So possibly we have to rethink and then see what we can do for our sepsis patient, extrapolate the data from the ARDS COVID-19 experience. But remember that extracorporeal therapies are complex. The mortality, which is mainly the primary indicator, depends many factors besides the age, the primary disease process, and the timing of intervention, as always. So in coming back to our patient, what happened? So we decided to continue the VV ECMO. We did not commit to the VA ECMO. We continued the renal replacement therapy or kidney replacement therapy, as you can see. We all decided that we are not going to pull the trigger for any blood purification system to the patient, and then see what's happened and have a long discussion with the family. You can think about that. Yes, we know that ECMO has definitely improved the outcome, but we are not sure whether the combination of ECMO and extracorporeal therapy will make a huge difference because of the complications and other unusual circumstances we bring to the practice. So without moving the goalpost further, so our team decided, according to the patient's family, almost after 2 weeks, that we need to stop the intervention and let the patients die peacefully, because that's not the best interest of the patients and their family. So we win the ECMO as well as the kidney replacement therapy, and then our 76-year-old gentleman dies peacefully with his family at the bedside. So that leaves us to the question, is extracorporeal therapy in sepsis for all, and are we there yet? The answer will depend upon this slide, that the extracorporeal sepsis, because I said in the beginning, the sepsis is the immune dysfunction. So that is, you have immune activation initially and then immune paralysis. If your intervention is towards the immune paralytic phase, nothing is going to work. However, finding that sweet spot of the immune activation as well as the immune paralysis is the future, and we need to explore that by some way, maybe precision patient care methods and some other devices or big data. And till that time, please do the best at your bedside and whatever available to your people. And I will stop there and take any questions.
Thank you, Dr. Guru, for this and the impressive talk. Before taking any further question, I would like to take opinions and expertise from the other panelists, Dr. Lobo and Dr. Professor Pradeep Bhattacharya.
Yeah. Thank you, Tapas. And I enjoyed that talk. As far as he did make the point that till date, whichever randomized control trial has been tried, and I used in the last 25 years, I've been enthusiastic about using most of these therapies, and then the randomized trial would come and say it doesn't work. So we used, all of us in India used polymyxin a lot till UFAS made us enthusiastic, and then Abdomix actually showed us that the need for renal replacement therapy was slightly higher in the group which got polymyxin hemoperfusion, and there was no mortality benefit. And Euphrates, by the time Euphrates came, they revised the sample size twice in the course of the trial, and eventually what they had hoped to show. The same thing happened with Ivore. When Ivore was designed, they said the control group would have a 60% mortality and they would show a reduction of 20%. When the final trial came out, it took them 5 years to randomize 141 patients, and the sample size calculated had been 460. So they fell to just 1/3 or less than what was the planned sample size and gave up for futility. And that was, the mortality was 41% in the control group, where it was supposed to be 60, and 38%. So the effect size was just 3%, and they were hoping to show a 20% difference. So clearly, even with the larger sample size, I don't think there would have been a difference. And then there came coupled plasma perfusion, coupled plasma filtration adsorption, and both compact and ROMPA were stopped early because there was a signal of harm. So early mortality seemed to be higher in the intervention group. And then, of course, and cytosorb also, I've never been able to successfully use it. Maybe that's my inadequacy, we're doing something wrong. But there was a 2017 trial in which, again, the control arm seemed to do better. And Psycho, which was published in the Lancet, that's a very peculiar trial because the cytosorb group did 4 times as badly as the control group in that. So that put me off cytosorb a little bit because the group seemed to be doing worse. And then there's Oxiris. Somebody's put a question about Oxiris. The biggest advantage to Oxiris and Hemophil seems to be that they provide conventional renal replacement therapy. So if we want to do renal replacement therapy, then Oxiris and Hemophil will do that for us. And the additional benefit of cytokine removal, endotoxin removal is an additional advantage. And Oxiris may be the only filter perhaps which removes both cytokines and endotoxin. So that's what I think about the extracorporeal therapies. There's a role in research. Seraph 100 is supposed to hit India shortly. I don't know. Maybe we'll be combining, as you said, pathogen removal with cytokine removal. In the future, somebody says it will be that we'll have to first do a mechanistic trial, find out which group is likely to benefit, rather than jumping into RCTs and prove after a lot of money and a lot of time finding that they don't work. Thank you.
Yeah, Dr. Lobo, thank you for the nice overview. And I completely agree with that. If you really wanted to use the simplistic without putting yourself in trouble, Oxiris will be probably the best way to go, because it's simple to use. It doesn't really additional resources, everything. But as you mentioned, the data is still there, like fuzzy, and it needs more kind of deep diving. And I think the last sentence of yours is pretty important for all the group to understand that, what we are looking into the question of so-called RCT to find a very complex pathophysiological benefit as well as complex patient. There are so many things working, probably may not happen, but again, seeing the signal and utilizing the appropriate therapies as well as moving the needles step by step, probably the future. And then more important is that, now we have very small amount of data, but, with the AI and everything's big data, and then collaboration like this, nephrocritical care, having different population, different set and realistic goal. As you said, that you cannot expect having a reduction in mortality of 60% with a therapy which has so many competing factors. So that's more important to understand, and then focus on the pragmatic trial is probably the future.
Yeah.